Welcome back to Pathology. Today we're going to continue the discussion of bleeding disorders. So a bleeding time is going to measure the platelet function up to the formation of the primary platelet plug. Aspirin and NSAID usage is going to increase the bleeding time, but the platelet count is normal. The other causes of increased bleeding time is going to be the Bernard-Soulier syndrome, thrombocytopenia, Glanzmann disease, scurvy, and von Willebrand disease. So the normal bleeding time is about 3 to 7 minutes. Normal platelet count is about 150,000 to 300,000. The prothrombin time is about 10 to 12 seconds, and it evaluates the ability to clot. Warfarin is going to decrease the prothrombin time. The partial thromboplastin time is about 25 to 38 seconds, and that's going to determine if the blood thinning therapy, especially heparin, is effective. And the INR is the International Normalized Ratio, and that ensures that the results from a PT test is the same from one lab to another. Hemostasis is going to be determined whether the fibrin has been dissolved by plasminogen, if D-dimers are going to be released. This is normal, but if there are elevated levels, that's a DIC. Von Willebrand factor is going to be stabilized by factor 8. Adams 13 is going to cut up the von Willebrand factor to lyse the thrombin, and it's found in TPP or TTP, and it can be caused by E. coli in this variant 157H7, and that causes the nephrotoxic disease. Hemostasis is going to be determined, or it's going to be described by the Virchow triad, where there is stasis of the blood, endothelial injury, and platelet function. So bleeding disorders can be either caused by the increased fragility of the blood vessel, platelet abnormalities, derangement of coagulation, and the vessel wall abnormalities show up as petechiae, purpura, but the clotting tests are going to be normal. Henoch, Schonlein, purpura occurs in childhood and adolescence, and it follows a upper respiratory tract infection. It's characterized by the hypersensitivity of the capillaries and the small vessels due to IgA. There's going to be rash, edema of the hands, scrotal edema, especially in usually it's because it's going to be infecting a young boy. And diarrhea, polyarthralgia, acute glomerulonephritis is going to be the most important. It can be caused by cross-reactive proteins, so it can be due to celiac disease or a herpetic form of dermatitis. So dermatitis caused by herpes-like dermatitis. Thrombocytopenia is the decreased production or increased destruction of the platelets. It can be also due to transfusion dilution, and it's characterized by sequestration in the spleen, so there's going to be splenomegaly. The most common cause is some kind of autoimmune disease, so TTP, thrombocytopenia versus DIC. In particular, there's a difference between PT and PTT ratio. In TTP, it's going to be normal, while in DIC, it's going to be increased. D-dimer is going to be normal in TTP, but in DIC, it's going to be increased. DIC is a complex systemic thrombohemorrhagic disorder where all the clotting factors and platelets are used up, and eventually there is too much bleeding. First, the initial phase is going to be widespread clotting. there's going to be deposition of fibrin on the platelets, and then it shows up in acute DIC as petechiae, purpura, and hemorrhagic diathesis. But in chronic, there's going to be the strokes, the PEs, and the infarction due to the deposition. But now with the thinning of the blood, it's going to be released from the vessel walls, causing the all of this, along with ARDS, which is the most serious, right? There's a lot of causes for DIC. It can be septic, it can be trauma, organ destruction, malignancies, and kind of placenta abruption, placenta previa. And yeah, first there's going to be the excessive clotting that causes the ischemia and the end organ damage, and then thanks to the conversion of plasminogen to plasmin, fibrinolysis is going to cause the excess bleeding, which is going to lead to the shock, the hypotension, and the increased vascular permeability. Both will kill. Importantly, there is no inflammation in DIC, so the hypotension, all of that, it looks like septic shock, but there's no inflammation. In the early hypercoagulable phase, the platelet count is going to be down. There's no schistocytes yet, but eventually they will show up along with the dacrocytes. The streptokinase is going to be found in the urine as urokinase, and the liver coagulation factors 2, 7, 9, and 10 are going to be first increased, and then they're going to be decreased in the manifestation phase. It can lead to the Waterhouse-Friderichsen syndrome or Sheehan syndrome, thanks to the coagulation. And you treat this with anti-TNF alpha and interleukin 1 to prevent the inflammatory cytokines and vasodilation, and to help with the coagulation, you're going to give fresh frozen plasma. Berger syndrome is an IgA nephropathy characterized by the red urine. In the nephrons, there's going to be mesangial expansion and proliferation. Platelet count is going to be normal. Bleeding time is normal, but the complement 3 is going to be activated, and fibrin deposits are going to occur. And the causes can be some kind of immune disorder. It is going to be activation of the complement pathway. It affects children after a strep infection. It's going to manifest as the vasculitis, purpura, GI bleeding, and more importantly, the glomerulonephritis. Unfortunately, it's more common in males. Thrombocytopenia is going to be decreased production of platelets due to aplastic anemia or leukemia, or decreased platelet survival, which can be due to complement activation or not. The sequestration is going to cause hypersplenism, that will lead to splenomegaly, and it can just be due to dilutions from the amount of transfusions. The immune thrombocytopenic purpura is going to be characterized by melena, which is a black tarry stool, and there are two types: primary or idiopathic. It's going to be self-limiting. It's usually seen in children during the spring or winter time. You don't really treat unless it's very severe. Then you give steroid therapy. It's characterized by the formation of antiplatelet antibodies, so antibodies to factor 2B, 3A, or 1B, or 9 complex. It's characterized by petechiae, ecchymosis, and nosebleeds. In chronic immune thrombocytopenic purpura, there's going to be heavy menstrual bleeding, melena, easy bruising, subconjunctival and retinal hemorrhages, which can lead to blindness. The complications, or the more serious complication besides blindness, is going to be your subarachnoid hemorrhage and intracerebral hemorrhage. You treat this by corticosteroids, immunosuppressants, and splenectomy. Secondary immune thrombocytopenic purpura is the most common. It's usually caused by drugs, which will cause the aplastic anemia. Leukemia will also be a cause. That's the bone marrow infiltration, hypersplenism, or systemic lupus erythematosus. It's more in women's, and there's a deficiency of the ADAMTS 13, which degrades the von Willebrand factor, and it presents with a lot of non-specific symptoms. Besides that, the more characteristic symptoms would be the neurologic symptoms, so important to know. The hemolytic uremic syndrome, it coexists with a bunch of other diseases. It can be due to malignancy, autoimmune disease, drugs, malignant hypertension, nephropathy, stem cell transplant, and it can be due to infections, so S. pneumonia, a strain of E. coli, particularly the O157H1 strain. It occurs in children. The triad is the schistocyte thrombocytopenia and the renal insufficiency. At first, there's no neurological manifestations, and the treatments would be dialysis or plasmapheresis. The antibiotics are contraindicated because of the antibiotic will kill the bacteria, and that can lead to the bacterial shock. So bleeding disorders are either related to defective platelet function or just a deficiency in platelets in general. The problem with adhesion, it would be Bernier-Soulier syndrome. Problems with aggregation would be Glanzmann thrombocytopenia. Defective synthesis would be some kind of storage pool defect, so bone marrow problems. And defective clotting would be von Willebrand disease, Hemophilia A or B. Von Willebrand disease, problems with the platelets adhering to the exposed collagen. The platelets will have a glycoprotein GP1B receptor for von Willebrand factor, and normally it complexes with factor 8 and protein C. Of course, if there's a problem, these are not going to be binding to the von Willebrand factors, and you use a Rituxan test to see if the receptor itself is defective or there's just a deficiency of the von Willebrand factor. Hemophilia A is X-linked. It's going to really affect major joints, and it's a deficiency of the factor 8 of the intrinsic clotting pathway, and it's characterized by the hemoarthrosis, so blood in the joints. There are no petechiae. Hemophilia B has very similar clinical symptoms, and there is only a deficiency in factor 9 instead of factor 8. And there can be splenomegaly and heavy menstruation. So that's it for now. Thank you for your attention, and good luck studying.